and I hope that you are okay with this. We are recording meeting in 2 languages, Russian and English, and recording will be available for those who want to listen to the workshop one more time, or who couldn't join workshop right now. So I guess that with logistic, we are all well. Again, I will repeat about the translation. If you want to hear us in English, please choose English channel. Если вам нужно услышать то, что происходит на русском языке,
Well, if you respectively would like to listen to the Russian interpreting, please select this channel for interpreting. It's the globe sign on the lower down part of your screen, and there you can pick up either English or Russian language for respectively listening to the contents of the webinar.
Okay, could we start? I guess we could. I'm Anna Dovbach, Eurasian Harm Reduction Association, and I'm very happy to start this webinar or workshop on elimination of hepatitis C among people who inject drugs. And we will discuss the situation in the Eastern Europe and Central Asia, and we are happy to have WHO office here and EASL representatives here, and a lot of specialists in hepatitis treatment and diagnostic here with us in the webinar. And actually for us as association, it is important moment when we are not, when we are bringing our key problems with access for people using drugs, access to treatment and treatment of hepatitis C in our region, bringing to you as a professional community of people who are treating hepatitis and who could help us as an activist in harm reduction, activist from community of people using drugs, to have access to this important life-saving treatment. So, and this discussion is just start of the dialogue between activists of civil society and doctors who are supporting, helping, and saving lives. And hopefully we will have a good discussion now, and we will find out how we could continue this dialogue and continue this toward the access to treatment. Actually, now I'm happy to introduce our first speaker, and actually to give us overview of situation with hepatitis C among people who inject drugs in ECCA region, and that will be and who will discuss with us and describe in details what are WHO recommendation toward this issue. And I'm giving a floor to Anton Smazalevskis from WHO Copenhagen office. Anton, please give us the picture. We will start with the general.
Thank you very much. Thank you very much, Ganna, and thank you very much also for initiating this meeting. I think it will be a really interesting meeting because of the speakers we have, and also because of participants who I hope will participate in the discussion. And as you know, the focus of this webinar will be on situation in Eastern Europe and Central Asia, but of course not only. So I will try to present very briefly the epidemiology of hepatitis C globally and regionally among people who inject drugs, but also will present some the main WHO recommendations, including what is in the pipeline. You know, we are currently updating our recommendations on hepatitis and also on key populations, and I will try to also brief you about what is in the pipeline. So with the first slide here is you can see here the global picture, and we know that hepatitis C is one of the key, one of the major infectious disease threats globally, and in 2015 it was estimated that there were 71 million people infected, and in all regions, and European region is one of the most affected with 14 million estimated living with HCV in 2015. Now, currently, we are updating the global and regional estimates, and in May there will be a new report published, and we will try to see if situation has changed since 2015. It really has changed. And if we look at the European region again, then out of these 14 million, more than 60% are living in countries of Eastern Europe and Central Asia. That's why it's the focus of this webinar. So if we speak about the epidemiology of hepatitis C in people who use drugs or who inject drugs, that globally more than 50% of people who use drugs or ever use drugs are infected with hepatitis C virus. And global hepatitis report in 2017 also estimated that 1/4 of new hepatitis C cases, this is globally, is attributable to injecting drug use. In some countries in Western Europe, we know that this number is even higher when there is a concentrated epidemic. And also we estimate that 1/3 of all deaths related to hepatitis C are also attributable to lifetime injecting drug use experience. So people, maybe they injected 20 years ago and that was enough with just one episode of drug use and they were hepatitis C infected. That's why it's very important to address hepatitis C in people who inject drugs if we want to eliminate it on a national level. And also hepatitis C and HIV co-infection is extremely high among people who inject drugs. It's over 80%. In some settings, it's over 90% and even more. So if we want to eliminate hepatitis C, what needs to be done, especially in countries with concentrated epidemics, but also in all countries with hepatitis C epidemics, because people who inject drugs live in every country and they contribute to the hepatitis C epidemic largely. So there were some modeling work done and it showed that a combination of effective prevention, including needle and syringe provision, opioid substitution treatment, and effective HCV treatment will reduce the incidence by 90% as set by WHO as elimination goal. So it shows that without addressing hepatitis C specifically in people who inject drugs, it will not be possible to eliminate hepatitis C. So speaking about the current recommendations for people who inject drugs and hepatitis C. So first of all, from our key population guidelines, there is a strong recommendation to scale up and sustain harm reduction measures to prevent incidence infection. And regarding testing and treatment, our HCV guidelines in 2018 strongly recommend a treat all approach. So all patients with hepatitis C infection with positive RNA need to be treated. In all guidelines, there is people who older than 12 years, but as I mentioned, we are updating and then we will review the indications. And also we recommend using pangenotypic regimens to simplify the diagnostic and simplify the management of HCV infection. And Dr. Mojca Matičić will tell more about EASL recommendations, which are mostly aligned with WHO recommendations. Yeah, you can see we're also recommending sofosbuvir daclatasphere as a kind of conditionally pangenotypic treatment, and but it's the regimen which is the most affordable and accessible in most low and middle income countries. So and there is no doubt that this is valid, and there are millions of people have been treated with this regimen. Also, structural interventions are part of a comprehensive public health approach, and these are so-called critical enablers, and they include supportive legislation, policy, and funding. They also include addressing stigma and discrimination and addressing violence against key population. It's including people who inject drugs, and importantly, community empowerment and involvement of the civil society organizations and communities in all parts of response. And there's also very strong synergy with HIV in prevention and care and other health issues. So in 2019, we conducted a policy review. WHO has revised all the country hepatitis action plan to see whether they are addressing specifically people who inject drugs. And then in 2019, 81 plan was assessed, and just a bit over 60%, including specific interventions for people who inject drugs. And only less than half of those country plans outlined the interventions in accordance with the global strategy, and even less were referencing interventions for prisoners, because there is a very big gap for this population. So what are the what are the main barriers for HCV treatment among people who inject drugs? And there will be more discussion in the next presentations, but on a general level, so we can classify them into the system level. So it's exclusion of people who inject drugs from treatment guidelines and national plans. Also, the fact that treatment is conducted in a highly specialized centers, which might not be adapted for people who inject drugs. This can also be a barrier. And also lack of harm reduction platforms is another barrier for scaling up interventions for hepatitis C among people who inject drugs. On the level of providers, so on the level of clinicians or treating doctors, there are concerns about adherence issues, concerns about reinfections and adverse events and drug-to-drug interactions. So that's why this all results in a reluctance to treat active drug users among clinicians. But this is changing, as we will learn from the next presentations. And finally, criminalization of drug use is, as we know, in Eastern Europe, all countries are criminalizing drug users, and this is against the public health approach, and that it also represents a major barrier to scaling up hepatitis C testing and treatment. Just one slide about the prisons, because prison population and problems with health problems of the people in prisons are directly connected with injecting drug use, because people who inject drugs usually are overrepresented in prisons. And some people even start using or engaging in more risky behaviors while they are in prisons. There are also some other risky practices, as tattooing present in prisons. And and most important, that the access to prevention and treatment is limited in prisons, and also the prevention activities are limited, like harm reduction. And also the other problem is, of course, the continuity of care between community and prison. But in the same time, we also understand that prisons is a unique opportunity for microelimination. And that's where the patients are actually, while they are in prison, they can be treated. And that's why it can also reduce the population level prevalence of hepatitis C infection. So last year, we published a first compendium of good practices in hepatitis response in European region. And there is a number of very interesting examples from our region, including service delivery models, the integrated multidisciplinary care with peer support, also point of care testing, and integration of HCV treatment in Georgia into harm reduction services. Also, there is an example from our next speaker about a micro-elimination of hepatitis C in risk populations. And also there are several examples from elimination of hepatitis C in prisons from Greece, Spain, and Luxembourg. So, and we hope that also Eastern European countries will follow those examples, and we will see more and more of this good practices in our countries. So since now is the time of the pandemic, I could not miss this opportunity to say just a few words. The slides will be shared, so I'm not going to go into details, but we know that there are certain challenges we face because of the pandemic, and several studies have been done to assess what are those challenges, and mostly of course, you all know that when there is a so-called lockdown, there is a lack of access to testing, and many countries have seen reduction in testing coverage, and also consequently a reduction in treatment initiation. Another study was done by Eurotest coalition or group of different organizations, and it showed again that in the time of the first lockdown, almost more than 50% decrease in testing was observed for all infections, including hepatitis B and hepatitis C. So, and since we also know that the pandemic is still, and actually now we see that the cases are still growing in all the regions, despite the scaling up of vaccination for COVID-19. So it will be very important to adapt the services to make sure that we don't lose the momentum, and so there is some recommendations by many international organizations, including by WHO, on how to adapt the services, and that includes a full treatment course for hepatitis C, engaging some community groups to support home delivery of treatment, more use of teleconsultations, and so on and so on. So there's also some recommendations how to catch up the services after the ease of the lockdown. So just then now few slides about what we expect in the near future from WHO, which new guidance is coming up. So you all know that the global strategy is coming to the end this year. There will be a global report in May to the World Health Assembly, but we already know that the executive board of the World Health Assembly has already agreed that there will be need to update the strategies, and there will be a broad consultative process to develop global health sector strategies with all the member states, partners, and civil society. And there will be also regional consultation, virtual of course, where we will discuss what needs to be included in the updated global strategy. We are currently also updating the guidelines on key populations, and there will be a focus on person-centered approaches. And you know, the last guidelines were kind of focused on HIV prevention, but this time there will be equal focus on HIV, viral hepatitis, and STI. So there will be a lot of focus on integration of the programs, or between the programs. There will be some recommendations on simplified approach and focus on evidence-based recommendations. And some of the new recommendations that we are expecting to be included is behavioral interventions for stimulant drug use, including chemsex, service delivery models, including online and peer-led services including for hepatitis, and also importantly testing and screening and treatment for recent HCV infections. That's what we usually called an acute hepatitis C. So now the new terminology calls it recent HCV infection, because it's not always symptomatic, but if we manage to detect it timely, there is an opportunity to treat it also timely. So about the hepatitis guidelines, we also updating our hepatitis C and B guidelines, and there will be new recommendations that are currently under development, including integration and decentralization of testing, treatment, and care, including in non-hospital services. We are developing hepatitis C self-testing guidelines, which will be published actually already this year by the World Hepatitis Day, hopefully. So there will be also some recommendations on point of care testing for viral load. We will include also regimens for children and adolescents. And again, as I mentioned already, treatment and testing and treatment of recent HCV infection for people who are at risk. So just to summarize the key messages, there is an ambitious strategy endorsed for elimination, and there are also defined packages with simplified treatment guidelines for hepatitis C especially. There are, to achieve targets, major access gaps will needed to be addressed through more affordable prices for hepatitis C medicines, for promoting and scaling up interventions for people who inject drugs and prisoners, and also promoting a differentiated and integrated service delivery model. And of course, we need to address on a country level, remove the structural barriers, criminalization, stigma, and discrimination, and provide access to harm reduction testing and treatment for people who inject drugs. So I would like to thank you, and if also to thank my colleagues who were working on this topic. Thank you.
Thank you, Antons. Thank you very much for comprehensive overview of the situation. And I wanted to ask if there are any clarifying questions from the audience. And we have luxury to have the meeting of all of us. And if you have clarifying questions, please raise your hand. And they could be the answers. And we have already a question from Butterbeck. And actually, you could ask questions in Russian. Вы можете задавать по-русски вопросы. Я надеюсь, что работает.
Yes, you can ask your questions in Russian as well.
And Antons, there is the question, are there any WHO recommendations regarding using HIV, HCV multi-testing approach for testing key populations?
So if I understand the question correctly, of course, this is part of integrated people-centered approach. If there is a risk for infection, both HIV and HCV, especially in key population, of course, there is a recommendation to test for all infections, but people might be at risk. But if the question is about the dual tests, so I think currently we cannot recommend it because they're not pre-qualified diagnostics, which can, if I understand this rapid test, which tests both for HCV and HIV. Of course, if there will be such a diagnostic, that it will, and if there will be quality assured and effective, that we will recommend it, of course. And if there is need for, there's another question, if there is a need for separate guidance for hepatitis B and C at the country level, I think it's up to the country, and I don't think there's a special need, but it depends also on what is the tradition in the country developing hepatitis C guidelines. But I don't think there is a specific need for a separate hepatitis B and hepatitis C guidance on the country level.
Thank you. And I guess that the question on the implementation strategies, that's something we will address in a half an hour, actually, and we will have some examples of the implementation. And I hope that participants could also share their challenges implementation in the discussion part of the meeting. Again, я еще раз повторю про перевод. Внизу
Once again, I'd like to repeat about the interpreting channels. There is an option to select either English or Russian. The simultaneous interpreting is taking place.
And we could actually move to the absolutely, for me, the revolutionary statement from the European Association for the Study of Liver, and for Mojca Maticic, professor, doctor, who will present actually the elimination goal and role of the professional association, the European Professional Association, in the response to the problem and recommendations which already developed by EASL. And for our region, for Eastern Europe and Central Asia, this professional position is very important. Dr. Mojca, please, floor is yours.
Thank you so much, Gana. And first of all, I'd really like to thank Eurasian Harm Reduction Association for inviting EASL, European Association for the Study of the Liver, as a partner in organizing this very important event. So good morning to everybody, ladies and gentlemen, dear colleagues, dear participants. It's really a great honor and privilege to be here with you and to get the opportunity of presenting you the EASL recommendations for a complex management of hepatitis C in people who inject drugs in the context of global hepatitis elimination goal. These are my disclosures. So as we've already heard and as we already know, 5 years ago, the advent of safe and effective treatment for hepatitis C, so-called direct-acting antivirals, really encouraged the WHO to set up the very ambitious goals, as been seen, to eliminate viral hepatitis as a public health problem. So to decrease number of new infected by 90%, to increase number of treated with DAAs to 80%, and to reduce deaths due to hepatitis C by 65%. Why focus on people who inject drugs to eliminate hepatitis C? Well, much have been said so far. 15.6 million of drug users worldwide, more than half of them infected with hepatitis C. 1.5 million of them living in the Eastern European countries. And strikingly for clinicians is that actually death from liver diseases, including hepatitis C, is equally common as death from overdose in those drug users that are aged over 50. And moreover, in the last decade, mortality due to untreated HCV infection has been increasing, particularly due to this late presentation of people who inject drugs. So we know that drugs, direct-acting antivirals, work not only on the individual, but also on the public health level. So to encourage the widespread treatment scale up, as we've already heard, in 2018, the WHO produced guidelines that advise all the countries that they should allow access to HCV treatment to all infected individuals, so-called treat all strategy. As you know, we have it in HIV, like test and treat strategy. So in reality, well, this was a modeling study, but it's clearly shown that the WHO treat-all strategy could bring about appreciable prevention benefits. However, as you see here, greater benefits per treatment can be achieved through targeting people who inject drugs. And it's also true for Central Asia, as you see, as well as for Eastern Europe. But as you know, the road to HCV elimination turned out to be really very complex. It includes awareness, prevention, testing, diagnosing, linkage to care, access to qualified health services. Usually treatment is performed within hospitals or clinics. And of course, all this process needs to be wrapped out by monitoring and of course, evaluation. It's needed anyway. But in reality, a cascade of care, or particularly for people who inject drugs, looks really very disappointing, because you know the proportion of drug users being included in this continuum of services presents rather a very, very decreasing cascade of care, with a very, very small proportion of those who get DAAs and those who actually get cured. And we all know very well that in every country, there exists numerous of barriers and gaps on several levels. So from the side of the patients, the practitioner, particularly the system and the policy. So solutions actually need to be found as soon as possible on the patient level, as well as on the public health level. And modeling studies, as well as also real-life studies, have clearly demonstrated that, if I may say, a magic bullet to overcome all those barriers and gaps is a so-called patient-centered care for hepatitis C. It includes 4 major pillars. Simplification, it means diagnostic and treatment algorithms should be performed if possible on one place, a one-stop shop. Decentralization, HCV services should be put out of hospitals to regional and local level. Task sharing, we should involve general practitioners, nurses to manage uncomplicated HCV cases. You know, we have many of uncomplicated cases. And last but not least, integration. So testing and treatment should be performed in primary care, harm reduction services, other outreach services, so within the community. So one of the strategic directions of the European Association for the Study of the Liver, so EASL, which is called itself a home of hepatology, is also to be a kind of advocate of the highest standards of hepatology care for patients. And so in the framework of viral hepatitis elimination, EASL also set up some hepatitis strategies in 2 directions. First is on the patient level, primarily by clinical practice guidelines. And second direction that EASL works for is public health level by including position and policy statements. So let's first have a look at the clinical practice guidelines, because these are here at the below, these are the clinical practice guidelines that have been launched in September last year. And actually, these are the final updates in the series of recommendations that started in 2014. And the aim of these recommendations is to assist physicians by describing the current and the most optimal management of Hep C infection in infected people. So the latest September 2020 clinical practice guidelines recommend that all treatment naive and treatment experienced patients with either recently acquired or chronic HCV infection must be offered treatment without delay. I just like to, as Anton said, point out again this new term, recently acquired. This is a new term instead of the former acute hepatitis C. It means de novo infection or de novo appearance of markers of Hep C infection within the last 12 months. So these last clinical guidelines urge treatment in certain patient groups and among those that are clinically important, also in individuals at risk for transmitting HCV, and these are also people who inject drugs. So according to the recommendations, people with a history of intravenous drug use include all of them, either former injectors who already ceased injecting, or recent or current, or those on opiate substitution treatment. And for all of them, it's recommended that they should be, for those who are still injected, they should be routinely tested at least annually and following high-risk episodes. They should be provided with appropriate access to opiate substitution treatment, other harm reductions programs, including in prisons, and all drug users, regardless being active, recent, former opiate substitution treatment, all of them are candidates for direct-acting antivirals and should be treated according to these recommendations. Well, as already pointed out by Antons, in Europe, according to the clinical practice guidelines recommendations and according to the practical use, there are 4 fixed combinations of drug use, so sofosbuvir, glecaprevir, pembrolizumab, ruzasvir, elbasvir, and sofosbuvir, voxilaprevir as a survival kit. But luckily enough, we do have 2 pan-genotypic HCV drug regimens within these clinical practice guidelines, and actually they bring about a huge advantage, which can bring about a significant clinical implication because they made it possible to simplify treatment of hepatitis C. This means that these 2 regimens may facilitate a cascade of care, particularly for such a vulnerable population of people who inject drugs, because this is actually the population that can benefit most from a streamlined care pathway. So it's real-life studies have clearly shown that both regimens have been shown to be highly effective and safe in various groups of patients, including people who inject drugs. This is the these are the data from real-world studies from Viral Hepatitis. You see former or current intravenous drug users, very high sustained virological response. This is Grazoprevir, Elbasvir. No, this is Glecaprevir, Pibrentasvir, and again, in those who are on opioid substitution treatment, very, very high sustained virological response. And as you can see, it's also very effective in other subgroups of patients. So what does it mean, simplified care for people who inject drugs? Where simplified care can be used in patients who are either treatment naive or treatment experienced, who are without cirrhosis or with compensated cirrhosis. And we always need to do a pre-treatment assessment, as you know. And of course, what we need at the very beginning is, of course, proof of viremia. But when it comes to genotype, actually genotype or subtype determination, if it is not available, if it is not affordable, or it limits access to treatment, then we can use these simplified treatment regimens to facilitate the cascade of care. Of course, we need to evaluate the fibrosis stage with non-invasive methods such as liver stiffness measurement or serum biomarkers, APRI or FIB4. These are inexpensive and reliable biomarker panels, but you know the cirrhosis must be identified, as some of the regimens must be adjusted according to that, and of course post-treatment surveillance for HCC is mandatory in some patients. But here is also good news, because with both pan-genotypic regimens, they don't require specific methadone or buprenorphine dose adjustment. However, other drug-drug interactions, of course, need to be taken into account. And now we come to treatment, because in this simplified care regimen, we can use only pan-genotypic treatment algorithms. And as you see, it is either Softwell for 2 weeks for all groups of patients, and Glecaprevir, Pibrentasvir 8 weeks for all of them, except for those with compensated cirrhosis Child-Pugh-A who are treatment experienced. They need 12 weeks of treatment episode. And finally, post-treatment assessment. To simplify this assessment, testing for SVR 12 weeks after a termination of treatment can be omitted in certain patients. In those, of course, who are adherent, and not in those with high-risk behavior and high risk of reinfection. Of course, they still require SVR 12 assessment and monitoring for HCV reinfection. The question is, of course, can SVR 12 be safely omitted? But this is the study including more than 100 recent injectors, and it has clearly shown, as you see, high sustained virological response and high adherence rates, even though forgiveness to adherence was quite high in this study. But as you can see, adverse events were not a problem, and one patient got reinfection. So what is with this reinfection after successful treatment? Does it represent a significant problem in this context? Well, the meta-analysis of 36 studies has shown that the overall rate of reinfection is not that high. In recent drug use, generally speaking, it was 5.9 per 100 person years. In recent injectors, it was 6.2, and in those on opioid substitution treatment, it was even much lower. It was 3.8 per 100 person years. So EASL strongly recommends that retreatment should be made if reinfection is identified during post-SVR follow-up. However, and very importantly, special attention needs to be paid to patients with decompensated cirrhosis with or without indication for transplantation, because these are definitely the patients that this simplification is not taken into account. So as you know, patient with decompensated cirrhosis, child Q, B, or C, should be treated in an experienced center with, if possible, easy access to liver transplantation. And keep in mind, very importantly, that protease inhibitor containing regimens are contraindicated in these patients. So you should use soft-vel plus either ribavirin, or in case of contraindication, or bad tolerance, then a longer period of soft-vel treatment regimen. Now, proceeding from the individual level to the public health level, we've already heard that broad accessibility to direct-acting antivirals can reduce the prevalence among people who inject drugs. And of course, very importantly, not only treatment with DAAs, but the combination of opioid substitution treatment and high coverage needle and syringe exchange programs can definitely reduce HCV incidence, and it has been shown in several studies by even more than 70%. But here is the reality. This is the reality from 2017, from 179 countries, showing that less than half of them implemented OST, a little more than half of them implemented needle and syringe exchange programs, and sadly enough, high provision of HCV testing and treatment was realized only in 1% of people who inject drugs. And as we just heard from Anton's, action plans were introduced in 2019 in 81 countries, but only 63% included drug users, and interventions were were included only in 46% of them. So these are very brand new data. I haven't put them on the slides yet. But very importantly, even in countries that do have high provision of testing and treatment, access is still limited due to several reasons: restrictive guidelines, stigma, discrimination, erratic case management, insufficient peer support, even poor awareness of therapeutic advances among people who inject drugs themselves. So these are the results of the recent study. These are the results also from 2019 from 35 European countries, showing that, as you can see, people who inject drugs, active drug users, are not allowed to get access to HCV treatment. And in some countries, even former injectors are not allowed to get access to HCV treatment. So EASL tries to be proactive also on the public health level by launching position statements and policy statements. So in 2019, during the International Liver Conference in Vienna, EASL launched a position paper with a key a position statement on elimination of hepatitis C, with a key message urging all European countries to develop a comprehensive hepatitis C national strategy or action plan. So it actually wanted to support the WHO strategy plans. And actually EASL urged to increase awareness campaign to combat stigma and discrimination, to implement harm reduction strategy, to make DAAs available at reasonable prices, to improve access to treatment and care, to treat particularly those who are at high risk for infection, and of course to provide rapid testing in all relevant settings, of course, particularly for those at high risk for infection. But we all know that most of European countries have laws that criminalize the possession and distribution of drugs. Of course, policies differ among European countries regarding offenses and penalties, but it has been quite clear that actually it has been quite clear that actually drug use policy represents a direct barrier to achieving the goal of HCV elimination. Why? Let me show you at least a few reasons for that. You know, the prohibiting the possession of drug paraphernalia hinders harm reduction service delivery and uptake. Many national laws impose severe custodial sentences for minor, non-violent drug offenses, such as drug use and possession. Furthermore, people who inject drugs are frequently imprisoned or detained. They do not have access to prevention measures, to other harm reduction services. Often they do not have access to testing, treatment, or they are forced to interrupt ongoing HCV treatment. And last but not least, laws criminalizing drug use reinforce stigmatization and discrimination of this group of patients. So during the 2020 Digital International Liver Conference, EASL launched its policy statement on drug use in the context of global hepatitis C elimination goal, because actually it's high time to react. So EASL said that in order to achieve the 2030 viral hepatitis elimination goal, it strongly recommends that all barriers to the uptake of healthcare services by drug users be removed by changing policies and discrimination that hinders access. And this, of course, includes also the decriminalization of minor non-violent drug offenses and the adoption of an approach which is based on public health promotion and respects human rights and evidence. What does it mean actually in practice? Let me show you. So it actually means that to eliminate HCV in drug users, combining activities is required. First of all, decriminalization of personal drug consumption and possession, but it needs to be integrated with such interventions as HCV testing, treatment, and counseling. And by such an integration, drug users can freely access centers of assistance regardless of their drug consumption. And the best practice, good practice for that is actually Portugal, because in the year 2000, Portugal was the first country in the world to decriminalize minor drug offenses, and beside that, focused on treating addiction. So both activities were introduced there, and the outcome was quite the contrary to predictions of many, many people in Portugal. And as you see here, after 2000, first of all, there was a reduction of problematic drug use, a reduction of drug-related harms, a reduction of criminal justice overcrowding, but most importantly, from the medical point of view, there was a decrease of drug-related deaths by 84%, a decrease of new drug-related HIV diagnosis by 75%, and in 2017, only 2.2% of new HIV infections were related to intravenous drug use. But of course, we are now in April 2021, and we cannot ignore that momentarily we live in an era where COVID-19 has changed every core, every cell of our lives. So EASL was active also in the era of COVID-19, because already in April 2020, together with European Society for Clinical Microbiology and Infectious Diseases, EASL launched the first position statement on care of patients with liver disease during the COVID-19 pandemic. It has been published in JHEP reports, and it's freely accessed through Google. And the updates of this report, of this recommendation, were given 6 months later, or actually in August 2020. But with the advent of vaccines against COVID-19, EASL also launched the position paper on the use of COVID-19 vaccine in patients with chronic liver disease, which has been published in February this year in Journal of Hepatology, and it's also openly accessed. So we all know that COVID-19 has already placed a significant burden on the national health system at this critical moment in the context of viral hepatitis elimination. This is our estimation. However, the modeling study that we see here has clearly shown that a 1-year delay in HCV diagnosis and treatment could result in an additional roughly 45,000 liver cancers and roughly 72,000 deaths from HCV by the year 2030 globally. So immediate action to improve HCV screening and treatment is needed to make these elimination targets attainable. And with only 10 years left to meet these WHO hepatitis elimination targets, I'm sure that all the activities and continuum of care services everywhere in the world needs to be in place as soon as possible. And I'm sure, this is my opinion, but I'm sure you would agree that the strongest voice for that was most probably the call to end this journey started by these three medicine Nobel laureates in the year 2020, Harvey Alter, Michael Houghton, and Charles Rice. And last but not least, EASL is a home of hepatology for all the physicians globally. So I'm kindly inviting you to have a look at its webpage and become perhaps a member of EASL. And I'm also kindly inviting you to actively participate at the next upcoming International Liver Conference organized by EASL, which will be completely digital in June, from June 23rd to June 26th this year. Thank you very much for your attention.
Thank you, Dr. Mojca. And actually, for us, that's the key question. Could hepatologists say their word and say for the criminalization of personal use and possession of drugs in order to have really elimination of hepatitis C? I have no specific question because there are plenty of some discussions on the EASL work, what should be and could be done, but there are no questions. If there are in audience, if you have any questions, please raise your hand. I will give a floor directly to ask. And I see Anton's here, and if I don't know which language you will speak. Anton's floor is yours for the questions and clarification.
Anton's or Anton, because my name is Anton, yeah.
Yes.
But hello everyone, and hello Antons, yeah. So nice to meet all you. Really good presentations and good fresh data and really strong messages on decriminalization. I already saw your reply, Antons, in chat regarding decriminalization, because it's always, you know, it's good that medical community supports drug users community in this advocacy and putting these messages of decriminalization and stigma and discrimination, but it's always a question to WHO. But if you are in line with this and if you are doing this work, so it's good. My question is about treatment and testing, which is unfortunately still one of the barriers on the ground in countries. So as we see from 2020 table, we see absolutely new, I mean, not new for the specialists, but quite new for our countries, regimens like pibrentasvir, glecaprevir, and software, which is not already new, but I mean that for majority, I think, of the countries of the region, even sofosbuvir, adipasvir, or sofosbuvir, daquatasvir is considering as a dream sometime, and you know, people from the community, especially because general population traditionally can have more access to treatment, so it's like a dream. But on the way to this dream, so I see how our countries are still catching up these EASL and WHO guidelines in terms of these new appearing medications. But regarding testing, are there any recommendation on testing? Because we are already working with phenotypic regimens, but medical personnel on the ground are still asking the long list of testing, even old-fashioned testing, which is relevant to interferon era treatment, but not for DAA. So, and are there any maybe fresh recommendations on testing? Because as far as I understand, there are just a few key testing, and which is and how are you trying to? I mean, you definitely know that testing is one of the barriers, and I mean, costs of testing sometimes for the patients is one of the barriers on access to treatment. So how EASL or maybe WHO is dealing with this point?
Well, thank you for this question. If I may answer on behalf of EASL, and EASL guidelines are quite clear regarding that question of testing. The basic testing is, of course, screening for anti-HCV, so for antibodies, and this is the screening test which can be performed, and it's very supported to be performed everywhere within the community, whatever, as long as you have anti-HCV. And if this test is positive, then you need a confirmation. And this confirmation is done either by PCR, so HCV RNA result, or you can use also the antigen HCV core antigen test, which is cheaper, actually, perhaps more accessible in some countries. So actually you can use one or another, but to start treatment, it's not enough just to get the impression of being infected. You definitely need a proof that you have a virus that has been replicating within you, within your body, within your liver. And in that case, then it starts to simplify, because then you do not need genotyping, you do not need actually quantifying how much virus do you have inside you. You just can start with pan-genotypic regimen. And since you mentioned the regimens that are used here in this part of Europe, like sofosbuvir, velpatasvir, and GP, glecaprevir, pibrentamvir, in these 2020 guidelines, EASL clearly says that if the countries do not have available or people do not have access to those two combinations, then of course the pan-genotypic combination of generic sofosbuvir and generic declatasvir, as I know you have available, which is safe, highly efficacious, affordable, and it should be used according to the EASL guidelines from 2016. So actually, but of course, these generics need to be provided by quality controls and guarantees the quality. But as far as you have sofosbuvir, declatasvir, of course, you should just use it in case that people are PCR positive or core antigen positive.
Thank you, Moitza. And I guess
sorry, could you hear me?
Sorry, Malyar, I will give you a floor afterwards in the discussion. Could I have it, please? We could hear you, but now we will actually have 3 more short interventions and then discussion session on the specific issues. I will be very fast in the presenting the key barriers, because our absolutely marvelous presenters already went through them. But from the point of view of civil society and community united in Eurasian Harm Reduction Association, we need to highlight several issues from our side as in our strategy. And we are very happy to have doctors and experts in line with us. And that's about the scale of the problem and the estimated number of people who inject drugs. And we all know that the key challenge in our region, Eastern Europe and Central Asia, is in the Russian Federation and Ukraine, with the number of people who use drugs, who inject drugs, and with the level of HIV and HCV. But we need to remember that not all people who inject drugs even have the social problems, but we all people need to have treatment. And that's the numbers which already presented by Antons, and we see that in 18 from 29 countries of our region, hepatitis C spread more than the prevalence of hepatitis C is more than 50% among people who inject drugs, and that's very a lot. And I summarized the key barriers and challenges in access to health and social care. And we are rarely saying about drug registry. Usually medical doctors saying, okay, registry is not the punishment. But in case of post-Soviet countries, drug registry is the punishment. And a lot of people who are registered, you need to be registered to get any drug treatment help or to get opioid substitution treatment, and this will cause a lot of social problems and even problems with employment and access to other social care services. So not only criminalization, but even such easy and used practices, drug registry could be the barrier for medical help. And actually, I need to highlight the key challenge in addition to criminalization, the key challenge in the funding of opioid substitution treatment and harm reduction, which is going lower and lower in our region with the decreasing of international donors funding. And unfortunately, state officials are not supporting enough harm reduction. And we have the general picture of the opioid agonist treatment or opioid substitution treatment access in different countries. And as Moitza absolutely highlighted, that it's not enough. And if we are saying that patients who are in opioid substitution treatment, they are more effective in treating or testing and treating hepatitis, then we could see that none of our country is really having enough coverage by opioid agonist treatment. And majority of countries have this level less than 20% of the people who estimated the people using drugs. With the needle and syringe program, we do not have enough coverage in majority of countries of the region, despite the fact that majority of countries have these programs, and sometimes even having needle syringe program or harm reduction programs within the HIV response measures, but not in HCV response programs. And this recognition that we need these programs not only for HIV response, but for all health and care support for people who inject drugs, who use drugs, that's very important recognition and understanding in the region. And actually that's all intervention I need to make, because we are as association and our members in the country working hard to ensure access to comprehensive care, comprehensive social and health care for people using drugs, and protecting their rights. And that's one of the reasons why we are happy to cooperate with the health doctors in this advocacy. So that's all from my side, and that's more a general overview of the barriers we all understand. And the price of the services and specific programs for treatment and testing access, that's the key challenge for the whole region. And actually, that's from the regional point of view, that's it for the webinar. But we have two examples from the countries, how they are overcoming these challenges. What are their recipe of the effective hepatitis C elimination among people using drugs? And actually, I'm very happy to give a floor to Dr. Maya Butsashvili from Georgia to share her experience in this. Maya, are you with us? And could you share your views on how to do this better and your experience from Georgia?
Sorry, can I have, thank you so much. Sorry, colleague, do you hear me?
Do you see my slides?
Yes, Maya, please.
Okay. So I will be talking briefly about our experience of integrating hepatitis C treatment with harm reduction services in our country. So Georgia is high HCV prevalence country with 7.7% antibody prevalence in general population and RNA prevalence 5.4%. And PWAD are the largest proportion of patients with hepatitis C. And we started in 2015, we started hepatitis C elimination program with support of US CDC and Gilead. So harm reduction services are cover very well in Georgia the needs. Actually, it's never enough, but still regional coverage is pretty good. So we see harm reduction centers throughout the country. So when we started the elimination program, there were a lot of concerns, and it's amazing to see the progress, how attitudes changed in this direction. I mean, at first, people believed, even officials, health officials, Ministry of Health and CDC, some people believed that injection drug users would have very poor compliance, and there was concern and even question, include them in elimination program or not. And at the beginning, I even don't believe that we had this shameful contract with patients. So they were signing that if they would take drugs during the treatment, they would not be eligible to get into the program. But fortunately, with the pressure of activists and social, environment, foreign experts, this contract was pretty soon removed. And we physicians never complied with this contract, and we still were trying to enroll people, of course, but still the fact that such contract existed in the country was not good at all. So some people were arguing, there were very strange misconceptions that people who inject drugs still have damage of their liver with the drugs, and why waste medications. And another concern was that illicit drugs would interact with DAAs and so on. But anyway, we progressed and attitudes changed, and currently we have these integrated services with harm reduction centers. So soon after beginning of the program, we did a little study comparing SVR rates among PWID compared to general population, and it was similar. And as the study was, I'm not providing details, but just mentioning those studies, which reassured people one more time that including people who inject drugs in the program was correct decision, of course. So the compliance was same. In some direction, when we were using interferon regimens, it was even a little better among PWID compared to general population. So, and then Ministry of Health made decision to start a decentralization process. First, we started treatment in specialized clinics. At very first time, we only had 4 clinics throughout the country. And then there was a decentralization group from Ministry of Health starting working on decentralization in harm reduction sites and primary care centers. So we worked on simplification of diagnostic algorithm. Recently, there was a question about tests needed to get enrolled in the program. We had the same problem because at the beginning we had huge list of tests, and then we tried to simplify this diagnostic algorithm. So we use FIB4 test for assessment of liver fibrosis. We all know this is a simple test using ALT level, AST, platelet count, and age. And for those patients who have undetermined FIB4 level, equivocal zone, we do fibroscan. And then among those who have low fibrosis level, they can continue treatment at harm reduction centers. For those who have liver cirrhosis, they are referred to specialized centers. That's a brief algorithm how we refer them. So at first there was genotyping done, but recently it's been 2 years already. We also removed genotype tests because we have pan-genotyping regimen now, and we no longer need genotyping. So this is monitoring tests. We see it's very simple. We only do CBC and ALT for monitoring, and we only do SVR test. At first, we were doing 4-week PCRs and end of treatment PCR, but now we only do SVR. That's all. So we did a little study funded by Médecins du Monde and CDC to look at the barriers of treatment among PWAD. So, and people were divided in 2 groups: linked to care, which means having RNA or core antigen test, and lost to follow-up, were patients who just had screening test and no confirmatory test. So we found 2 variables associated with lost to care. One was knowledge of additional tests needed. So many of them who were lost to follow-up said that they didn't know that they needed further tests, which means that, of course, communication needs to be improved, because many times we know that people are having screening tests and there is no good communication with them what to do next. There are also people who, it's not only among PWAD, but also other patients who even don't know they had test. And we find their test result in system, but they never heard that they even had screening test. Unfortunately, this is still now the practice. So we need better communication after test result. Another variable we see how significant is statistically, it's financial accessibility. Most of them were saying that they couldn't afford further tests, because at the beginning of the program, there was patient co-payment. But currently, for the last 3 years already, government removed all payments for the tests. So everything is free now. All screening, confirmation, baseline tests or treatment monitoring tests, all are free, covered by government, which made, of course, much easier to enroll people, especially PWAD, in the program. So we also did patient satisfaction survey to compare satisfaction of PWAD treated at harm reduction sites versus those who were treated at regular specialized clinics. So we didn't find any differences in satisfaction. Patients felt okay, absolutely satisfied with the treatment at harm reduction sites. And even there was better timing, turnaround time in harm reduction sites. We see here that 42% of patients at the harm reduction sites versus only 4% started treatment within the first 2 weeks from the screening, which means that at harm reduction sites, enrollment in treatment program is happening faster. I just want to remind that at these pilot sites where we started the treatment, PCR confirmation is done by gene expert methods on site, so which makes it much faster. So, and also quality of services and perceived satisfaction of patients was absolutely similar in specialized sites and harm reduction sites. So we had challenges, and still we do have. The treatment integration process took much longer than previously expected and planned because of a lot of bureaucracy. Ministry of Health regulatory agency requested multiple rearrangements at harm reduction sites to meet regulations for treatment integration, because they kept saying that these are not clinics and how they can treat them. So they needed a lot of renovations and some reorganization and so on, but we overcame these barriers, and 4 sites met these requirements. So we needed, as I said, several steps of adjustments, but now we have a lot of challenges with extension of other sites, because at the beginning we had a plan that if these 4 pilot sites would work well, we would expand it to other harm reduction sites. But unfortunately, And one of the reasons, of course, is pandemics also, but again, bureaucracy is one of the major barriers. Expansion to other next 4 harm reduction centers is pending, and we are waiting endlessly for the approval from Ministry of Health. But still, that's what we achieved so far, and thank you for your attention.
Thank you very much, Dr. Maya, and actually thank you for all the program which exists in Georgia, and that's very important for all over the region, the experience and way from excluding people using drugs from the program to full inclusion. And I hope that the funding for harm reduction sites also will be somewhere in the national hepatitis program, to keep in mind that these sites and need to be funded as well for the whole complexity of services they are providing, which now includes testing and treatment for hepatitis. Thank you, Dr. Maya. And now we will have in Russian language intervention from Sergei Biryukov from Kazakhstan. I'm saying that it will be in Russian because in order to all participants who are listening us in English, please find the translation button in the down there. You will see the globe, and please choose English channel to hear what Sergei will share about the experience in Kazakhstan. Сергей, вам слово про опыт из Казахстана.
Sergei, the floor is yours about Kazakhstan experience. Colleagues, good afternoon. I am without any presentation, and I will be very brief, but I'll try to concentrate on something that Kazakhstan was able to achieve in elimination of HCV. We started it in 2011, and then interferon was bought because other medicines were very expensive. By 2018, only a small amount of patients, about 6,500 people, were included into different programs of treatment. In 2017, we started active work with our Ministry of Healthcare in Kazakhstan, which was extended in 2018, and from 2018 in our country we started procurement of Sapozbuvir, Daclatasvir, generic drugs, but which are approved for treatment. In 2018, with decrease on prices for antiviral medicines and DAA, we bought a lot of medicines for 18,000 of patients with confirmed diagnosis. And such large procurement enabled us already in 2018 to close the waiting list for those who wanted to be treated hepatitis C, that first of all enhanced the scene, increased the coverage, and today in 2021 in our country the applied formula is elimination of HIV. So you don't have to be placed on any waiting list. If you are confirmed the diagnosis, you go through all algorithms and then you get the treatment as prescribed. I wanted to once again mention that there are no restrictions on treatment finance-wise. According to the order of the government, all patients that are confirmed hepatitis C receive the antivirus therapy. In the last recommendation and regimen of Kazakhstan on treatment, there is one issue according to which the treatment for people with risks or at risks, including IDUs, is a priority. So, except for that we provide coverage to all patients already according to one program, we in our protocol have one more note or cause that people who use injective drugs have the extra status in order to be included into treatment programs. The entire diagnostics, including fibroscan and other quite expensive tomography and magnetic resonance, is provided free of charge within this pool of funds for medicine and assistance and treatment. What else do we understand as diagnosis? Diagnosis in order to prescribe ART and then control tests after the certain period. So once again, I'd like to draw your attention that all diagnostics is provided free of charge. It's covered by the government. Medicines, sofosbuvir and valparasvir, after 12 or 24 weeks are provided also free of charge. They are dispensed according to the schemes on providing treatment and care. We also mentioned sofosbuvir valparasvir, and I wanted to mention that last year we didn't have a registration of such a medicine earlier. As long as it was registered in 2020, it was at once included into the schemes of treatment for free delivery. And in the nearest future, we are awaiting the sitting of our commission on including of this medicine to then further be provided to key populations and all people who need this treatment. So this is the very brief overview. This is the universal coverage in Kazakhstan, and I'm proud that we did all possible in order to introduce such schemes. And the only barrier today is a wish of our patients to be included into the treatment. At the beginning, we had therapy provided in hepatological centers, but then the coverage was expanded, and this position now is expanded to diagnostics centers in any medical organization, irrespective of profiling, be it hepatitis clinics, private establishment, or any other healthcare institution. They all provide this treatment and can accept this person to a program. So it's open with us, and I think we have to be proud about it. And the only barrier is the wish of patients to be included into the program, to be tested, diagnosed, and then included into treatment. Thank you. That's it from my side.
I have one question. У меня есть вопрос по тому, есть ли возможность у пациентов опиоидной заместительной терапии, хоть их и немного,
Do the questions on OST, although they are not numerous, do they have the access for diagnosis and for specialized help? And the same with people who are getting harm reduction services in Kazakhstan. Is there any correlation between these two services? Anna, one more time, I would like to bring to your attention that we do not divide between social groups. So we do not categorize. The patient on OST or any other treatment can go to any medical institution and can have diagnosis and get the drug. So there are no barriers anywhere. Nowhere it is being stated in the documents that only people who use drugs or other groups can get this or that treatment. So you can just be referred to any medical organization and get the medicine. We have very good projects, and we already have in Almaty, in our city Almaty, with the center, we have a special project. So most probably we're going to pilot this project 1 or 2 times per week. We're going to see the patients who inject drugs, so that we can see how it goes, and so that we can most probably not. This experience is going to be not only in Almaty city, but everywhere in the country. And very often from people who use drugs, they usually say, I don't have the time, you surely understand me, I don't have the time for all these procedures. Although everything is simplified these days, everything is so simple, you only need the wish to do it so that you come there and you get all the treatment necessary. So there are no barriers, as I have mentioned.
Спасибо, thank you.
Thank you.
And actually, what we are doing now, we have some time for discussion and for comments, and I will encourage the doctors from Eastern Europe and Central Asia, first of all, to clarify, to ask questions. Maybe you have something to say. And I see the comment from Tatiana Kuchuloria, who want to comment something on Kazakhstan, and maybe while we will hear from Tatiana, we could ask other participants from the region, maybe you have some thinking, doubts on the role of doctors in this decriminalization or providing services through harm reduction. Tatia Kuchuloria, there was the question on how to как обустроена программа скрининга в Казахстане? I guess if it's question, then
the question about screening program in Kazakhstan from Tatiana. Tatiana, thank you so much for your question. I would like to comment and say that we have been trying to actively do screening for hepatitis C in our country. But unfortunately, this program and all these developments coincided with COVID-19 situation and pandemic. And unfortunately, and I'm sure it happened in many countries, all the priority at the moment is given to COVID, not other diseases or programs. But of course, we're not leaving this topic. We're not leaving it behind. We're just waiting for the situation to stabilize. And then together with the Ministry of Health, we are going to again work on this program, especially screening on hepatitis C. So it is all coming, I'm hoping. But the Ministry of Health is already collaborating with us and we can make some decisions, I'm sure.
Okay, Сергей, есть еще один вопрос.
Sergey, one more question.
По Казахстану.
On Kazakhstan,
насколько криминализовано
how criminalized is the use of drugs and keeping drugs? Colleagues, most probably I will not be able to comment on criminalization because this is not my field of expertise. If we speak about treatment and care and screening programs, also hepatitis C, and so on, I can speak about it, but I cannot speak on criminalization. I'm sorry, this is not my field.
Okay, thank you. And I will share more data on the criminalization of drug use, how it's punished in Kazakhstan from our side, because we have this drug calculator you could see. And that's one of the key issue that sometimes for doctors, this criminalization and drug policy could become the area of interest. We have one intervention from Vitaly Rybinchuk from Moldova. Vitaly, please introduce yourself.
Vitaly Rybinchuk, я из Молдовы.
Vitaly Rybinchuk from Moldova, member of the Association of European Association of People Who Use Drugs. And thank you. So we are waiting for the recommendations from WHO so much, and we are going to base our advocacy on it. And we're hoping that the recommendations will support our advocacy activity. Very interesting presentation from Georgia for me personally, and I would like this experience to be dispersed also in my country. This is what I wanted to say about what we're thinking on the fact that in the situation in Moldova can show also the situation in other countries in our region. In Moldova, we had to utilize a lot of pills for hepatitis C treatment because the state declared that we have unlimited access to this treatment and diagnosis. But we, community of people who use drugs, we did not agree with this. And the fact that the state utilized the pills that were procured proved to us that we are right. And how did this happen? Because our state officials were declaring not truthful information. And here I would also like to say that when something is declared, but in practice, it's a completely different situation. And the only thing how you can know it is if you're a patient, or if you are a patient organization, or if you are a community member, because we know that access to diagnosis in Moldova, and I know it for sure, and I know it about other countries also, does not correspond to what is written on paper in official sources and what state officials are saying in their speeches. So the person who suddenly gets to know that maybe he is infected with hepatitis C, the person does not have medical insurance, for example, and then this is the case when the person cannot diagnose, cannot do the fibroscan, and we started advocating these cases, and we have reached the situation when this access was granted. For genotype, for example, this test for genotype, and we have reached this. It's a victory on our side, but fibroscan is inaccessible because fibroscan, I'm speaking about Moldova, you can do it only in the capital city and only if you pay. It is not for free, and the price for you might say it's not high price, but people in our country, the unemployment at the moment the unemployment rate is very high. Many people go abroad to earn money. So usually people who use drugs, they just don't have the money to afford fibrosis. So I will not speak any further about this, but many of us did not get the treatment, although this treatment had to be accessible. And it's not only, as a result, this situation is not only for people who use drugs, but all these pills were utilized. Then in the budget line, they again have the budget line for the new pills, and then again they will get rid of all those pills, and also saying in the official statements that access is unlimited, but it is not true. So of course we are advocating these cases, and we want to lower the barriers, and we want to have full access to treatment, and we are hoping that through the programs of harm reduction we can do it.
Thank you, Vitaly, for highlighting the role of people who use drugs and community of people who use drugs in this advocacy. And I don't see any raised hands. And actually, there were several specific questions from the point of view of treatment and diagnostics. And now we have actually floor if our co-presenter, my co-presenters, have any final words or comments, or maybe you have something to say to summarize your answers to the questions. Yes, Dr. Moitz, please. Please unmute yourself.
Thank you. So Gana, thank you once again. And really, I'd like to express utmost gratitude to Eurasian Harm Reduction Association for this initiative, to getting us all together in such a group all the stakeholders today to discuss of such a vital topic. It was very instructive for me as well, and I'd really like to be a part of such meetings, as you know, because I do firmly believe that the tools that we presented today, and actually this knowledge, what works and what does not work, this eventually must enable health systems, and I think all the key stakeholders, to start at least reducing these barriers and to accelerate this progress. And despite this reported progress from some countries, and I congratulate Georgia, especially Kazakhstan, because I was not aware that they made such a huge progress. I think improvements of this continuum of care interventions for drug users are absolutely needed, but they may be achieved only by including also the harm reduction and drug use organizations. If it's not clear now, then I don't know what to do. So we need to include harm reduction and drug use organizations into all strategic planning of these services for a continuum of care, for testing, treatment, and for linkage to care. Don't forget that, because testing may happen within the community and then there's no linkage to care, which happens perhaps at the clinic. So the roles and responsibilities, not only at the health, but I think also beyond it, need to be defined with every country with respect to their delivery of hepatitis services. And I think that by involving all the stakeholders, I think a significant step forward can be made towards these elimination goals, which will change, as Anton's told us. We are anxious to waiting for May. So thank you very much.
Thank you. Pons, do you have any comments, final suggestions to participants?
Thanks, Ganna, and thanks, Moritz. I don't see if there are any questions, but of course, people are welcome to send questions. And I think it was very important also to hear comments from the community, from Anton and from Vitaly, because, I mean, we theoretically know about the barriers, but sometimes these barriers are not obvious, and it's very important to involve and to hear the voice of the communities to understand what are these problems in real life, because it's not, as you could see, it's not always obvious, and we can say that there are no barriers and everything is provided for free, but without the experience from those people, we would never know what are the real barriers and where we have to work further. Anyways, thank you. I hope it's just the beginning of this discussion, and looking forward towards the continuation of our initiative. Thank you.
Thank you very much. And from my side, I need to say that yes, it's not very easy to build alliances with the different doctors, because the doctors are gods in treating us. But in the same time, the voice of doctors in discussing of harm reduction and drug policy is so important, and that's actually sometimes very brief word from the doctor saying why we are not working with harm reduction services, why opioid substitution site have no connection to the hepatitis testing and treatment. This one comment could save the program and give the real elimination of hepatitis among people using drugs. Actually, that was the webinar and all meeting about it. Hopefully you get some new information. Hopefully you get some understanding how it could work better. I have one hand from IBEC. Please introduce yourself if you want to say something. IBEC, please. Floor is yours. You need to unmute, and if you could show your face, it will be also good.
Здравствуйте, меня зовут Айбек, я заместитель директора Республиканского центра.
Hello, I'm Aybek from Kyrgyzstan, from deputy of the director of AIDS Center. I will switch off my video because it's not a good quality, but I want to say that in the framework of state program, we are treating hepatitis C in people who live with HIV, and we have treated the majority of people with HIV who have hepatitis C. It doesn't matter if this is general population, MSM, or people who inject drugs. And we have a problem in our country. There is no focal point, there is no organization, hepatitis C, who would take care of this problem, of this situation. So if now among people who use drugs, there are going to be any activities, let's say, I don't know where people could go, where people could get the answers for their questions. I just wanted to say that WHO Europe could collaborate maybe on this issue because we need a systematic approach on services on hepatitis C in Kyrgyzstan.
Thank
you.
Thank you very much. And there is one more comment from Sergey Biryukov from the EMEA country, from Kazakhstan. Sergey.
Анна, Антон, я в качестве предложения хочу...
Anton, I would like to suggest or ask if you have any cases when medical services were not, for example, in Kazakhstan, were not realized on hepatitis C, or any correlation in relation with the community, please give my contacts, because we are ready to give training seminars. We are ready to refer patients to medical organizations, and we are ready to fight for this free access to services. Please, I'm sure you have my contacts, so please always share my contacts if you hear about any problems. And I have a lot of experience in this sphere, and now we are also working with HIV positive people, so I'm sure that we can also help people who use drugs 100%. So this is my suggestion and my question to you. Please share my contacts whenever it's needed. I am always happy to help.
Thank you, Sergey. And actually, that's experience. That's example.
Sergey, please leave your contacts then.
Could be on help to solve the everyday problems in access to services. And actually, that's the answer, the good answer to the question of Dr. Aybek. In Kyrgyzstan, there are several very strong community organizations, and we hope that this initial call with the doctors, then we will follow up with our members of Eurasian Harm Reduction Association, if they could take this information and accumulate the information on the hepatitis C treatment, the testing and treatment for people who use drugs, and how they could step in this advocacy and this cooperation. Thank you. I guess that's a point where we could finish our dialogue for now. It's not the last stop, and we definitely will continue this dialogue. And I'm tremendously thankful to Moitza and to Antons for co-organizing this event. And actually, hope we see each other maybe on the national discussions and on the regional discussions of this issue, to ensure access to hepatitis C testing and treatment among people who use drugs in the Eastern Europe and Central Asia. Thank you very much. We will share with all registered participants who came and go, or who could participate only partly, the video of this call and presentations in 2 languages. And thank you very much to WHO office for offering us opportunity of hearing this webinar in 2 languages, for translation and for bringing all us here together. Thank you very much, and good luck and have a good day to all. Then we are finishing. Thank you. Bye-bye.